Good afternoon. Welcome to another edition of McMaster Perspective. It's my pleasure to welcome Professor James Douketis, who is also our section editor for venous thromboembolism in McMaster Textbook of Medicine. Professor Douketis, the first thing I would like to do is to share the screen for a moment about describing the paper which generated today's discussion. It's about bleeding risk with Apixaban and rivaroxaban. But maybe before we go into it, you could present some background on oral anticoagulants.
Thank you, Roman. It's my pleasure to be part of this session. This is a landmark trial because it is the first large-scale randomized trial comparing two different direct oral anticoagulants, or DOACs. But to step back for a moment, what are the DOACs? So there are four of them. There are once-a-day preparations like rivaroxaban and edoxaban, and there are twice-a-day preparations that are Apixaban and dabigatran. All of these are now generic in many countries, so their costs have reduced substantially, and they are by far the dominant anticoagulants available for clinical use, principally for the prevention and treatment of venous thromboembolism, and for stroke prevention in patients with atrial fibrillation and some other indications as well. Let's just consider, before we get to the paper, just an overall principle that I try to convey to people, and that is that these DOACs are not the same. They should not be considered interchangeable, and you should tailor the treatment and the choice of the DOAC, as well as the dose of each DOAC, according to the patient and their individual characteristics. So let me just give you some personal reflections on this and examples of where I use these drugs. Apixaban, which is probably the most commonly used of the four DOACs, is something that I use especially in patients who may have impaired renal function, and even those are on dialysis, as well as patients that are at heightened bleeding risk. The other twice-a-day drug, dabigatran, which is not used very often, I would use in patients who have severe liver insufficiency as an example, because this is the one that is not dependent on the liver for clearance. And it's also been shown to have very good efficacy for stroke prevention in patients with atrial fibrillation. Edoxaban is also not a very commonly used DOAC, but I use it especially in patients who I'm concerned about drug-drug interactions, because it has the least interactions with other drugs. And it's probably the simplest to use because it's once a day. You can take it with or without meals, so if you want to ensure compliance. And that leaves us with rivaroxaban, which is the second of these drugs that came on the market about 12, 14 years ago. And I'm using it in other indications for secondary prevention of recurrent venous thromboembolism, maybe in peripheral arterial disease in a low dose. So remember to try and tailor your treatment and the dose of the DOACs according to the patient and their individual characteristics.
One question to clarify. You mentioned renal failure with the use of, I believe, Apixaban. Up to the level and including dialysis? Where do you see use of DOACs in renal dysfunction patients? Maybe it's a side issue, but you mentioned it.
This is an important emerging area, Roman, whereby we're seeing the use of Apixaban in particular in patients with impaired renal function. And you have to remember that when these drugs were first came out on the market, they were contraindicated. in patients with severe renal insufficiency, which, as you know, is defined by creatinine clearance less than 30 ml per minute. But there was increasing evidence from observational studies mainly that apixaban, which is the one that is least dependent on the kidney for clearance, could be safely used and, in fact, would be better in terms of efficacy and bleeding risk in patients not only with severe renal insufficiency, but also in patients who were dialysis dependent. So, warfarin is still an option in these patients, but less and less we're using that instead of a DOAC like apixaban.
And the dose of apixaban in severe renal insufficiency would be, if used, at the lower end, I suspect?
There aren't any clear recommendations about this. Because, as I alluded to, the studies are not definitive. They're retrospective, mainly studies. And in my practice, what I would do is I tend to follow the guideline for use of apixaban according to body weight, according to age. So that means that, assuming that all the patients have severe or end-stage renal disease, I tend to use a lower dose, which is the 2.5 milligrams twice a day, in smaller individuals, less than 60 or around 60 kilos, or more elderly individuals. And in a younger population, let's say 80 to 90 kilos or less than 75 years old, as an example, I'd go to the 5 milligram, even if they're on dialysis.
Okay, so let's move to the main topic, which is comparison of efficacy and bleeding risk. That's one of the unusual. You rarely see two ACE inhibitors compared, or two anti-lipid therapies, or two SSRIs for depression compared head to head. How it came about, and what's your take on it?
There was precedent to comparing different DOACs across in the past. Typically, we would be comparing different classes. So we would be comparing a vitamin K antagonist against a DOAC. This is different because we're comparing not only a DOAC, but we're comparing a DOAC that acts with the same mechanism. So these are oral inhibitors of coagulation factor 10. So they mechanistically, they work in the same way. So, I think the question was, why do this trial? The answer is that for many years, clinicians have suspected that a twice daily regimen of a DOAC is safer than a once daily regimen of a DOAC, and specifically apixaban versus rivaroxaban. So this was our clinical impression. And in fact, if you look back at the literature, this has been substantiated, because even back 5 years ago or 6 years ago, there were retrospective studies looking at large number of patients. So, for example, a study looking at 20,000 patients with acute venous thromboembolism using linked administrative database records, showing, in fact, that apixaban was safer and actually even more efficacious than rivaroxaban for the treatment of acute venous thromboembolism. Moreover, there have been retrospective studies looking at hundreds of thousands of patients with the indication of atrial fibrillation, showing very similar results, that apixaban is safer and perhaps even as or more efficacious than rivaroxaban, which is why the results of the study, albeit it's a landmark trial, was not surprising to many of us when the results came out, because we sort of thought about this based on our clinical impression, if you will, and it was substantiated by prior research.
Well, it was quite a effort over 7 years and numerous countries, so obviously an important issue. Why do you think this difference occurred, the difference in risk?
Well, that's sort of the ultimate question, if you will, from a scientific standpoint, because as I said, these are drugs that work in the same kind of way. What's different about them? One is given twice a day, the other is given once a day. Maybe with the once a day drug, we would expect that there would be higher peak levels of the blood thinning effect. The other reason, which is probably more likely in this study, was the way that patients were treated with acute venous thromboembolism. In the patients who received rivaroxaban, they received 3 weeks of a more intense dose, and then they were tapered down to a standard dose. Whereas with Apixaban, this more intense dose lasted for only a week. And we did see most of the bleeding events that separated the two groups occur within that initial 3-week period. So it's probably the way the drug was administered, once a day versus twice a day, and the intensity of the dosing that was administered. Now, remember, this is what is used for the treatment of acute venous thromboembolism and pulmonary embolism. It is not what we do in patients with newly diagnosed atrial fibrillation, which is the dominant indication for anticoagulant therapy nowadays.
You would be putting them on a steady, lower kind of dose. This is the graph you are referring to, where majority of excess bleeding occurred actually within first 3 weeks, and then more or less the lines remain parallel, correct?
Yes, that is correct. And I think the authors acknowledge that. And this kind of makes sense biologically and what we see clinically, because we know that when bleeding occurs after initiation of anticoagulant therapy, it typically occurs mostly, it's clustered within the first 2 to 4 weeks. And what we're seeing here is that effect, but it is accentuated in those patients randomized to receive rivaroxaban.
Rivaroxaban, yeah. Is there a reason why rivaroxaban would be used in increased or higher dose for 3 weeks and apixaban for a week? Or this was simply how the studies were set up to start with?
Yeah, I think you hit the nail on the head, Roman. It's the way the studies were initially designed. Remember that before these drugs were available, it was uncertain whether they would be efficacious for acute venous thromboembolism. And when you consider the use of the other DOACs, Apixaban and dabigatran, they kind of followed maybe a safer route because they started off with a heparin for 5 to 7 days before transitioning to an oral agent. Whereas with the Apixaban and dabigatran, they just started straight off with an oral agent. And maybe in retrospect, you can say the developers of rivaroxaban were really concerned about efficacy, and that's why they had a longer high intensity period.
Mm-hmm. Let me try for my own conclusions from the paper and what you are telling me. People who are on rivaroxaban for longer period of time and currently on the maintenance long-term smaller dose, so to speak, there really is no need to do anything dramatic about their drug or their dose, correct?
Well, you touch on a broader issue, is that how do we generalize these results to practice, both for patients who are currently receiving anticoagulants or may have a new indication for an anticoagulant? Let me start with the easier part, which is if a patient's receiving long-term secondary prevention of thromboembolism with either Apixaban or rivaroxaban, both in low-dose regimens, there's no real compelling reason to change that. Secondly, when you are initiating treatment for stroke prevention and atrial fibrillation, remember that you're not using a heightened intensity dosing for 1 or 3 weeks. You're starting them on a standard dose. So I don't think there's a compelling reason to change or consider one or the other. This study applies to patients who are initiating treatment for acute pulmonary embolism or deep vein thrombosis. And, as I said before, it's something that we're been doing already. The market share of these drugs reflects that practice. Prior observational study supports that practice. And now we have a high-quality randomized trial to consolidate that impression and prior research.
Well, it puts it into perspective. It differentiates between starting with a regular low-dose maintenance treatment and acute dose. And I think this information is both useful and frankly reassuring to people who are on different oral anticoagulants. Thank you very much. It's very helpful to me, and I hope it is helpful to our listeners. Thank you, Dr. Douketis.
Thank you as well, Roman.